Dr. Amdekar, this is for you, so that if someone is observing a medical error or a medical negligence happening in a hospital, let's say like KEM or Wadia, how do they report and what should the administration do? What's the role of the administration in this kind of situation? Because I guess the resident is not going to rat out on another colleague and say, oh, that colleague was called at 3 o'clock in the morning, but he never bothered to turn up till 6 o'clock in the morning, which is why the patient took a turn for the worse. And you don't want to tell anything bad about your friends or whatever. And I'm sure that must be happening. What do we do to prevent some of these situations and make sure that they don't happen?
I think knowing that the negligence also does occur. And therefore the best thing that we found was the negligence starts right from the casualty, where an adequate precautions have not been taken to see that the child is sick and needs to be hospitalized, sent back home and comes in 4 hours on the fly. When such thing happens, we take it very seriously. And now last 2 years we have got a CCTV in our casualty in our areas where we want to see exactly, because today every relation comes with a cell phone and he's even trying to videotape what's happening. I had relations who come and said that, sir, this is the video, your doctor was just on a WhatsApp and he was not looking at my patient for 10 minutes. He gives me a proof. It becomes very difficult. All that I would say is, yes, I think I have taken a note. I am very sorry for what has happened and I will see that this doesn't happen. The moment I say that, he says, no doctor, it's not a complaint, but such things should not happen to the next patient, and I am relieved that he is not going to take me to the court. But just because I said, I understand and I think it's our mistake. There have been the relatives who have said, doctor, I feel you should not allow him to continue to be a doctor because he was very negligent. I said, yes, I'll take a call. One of the relations have phoned me again and said, I hope management has taken an action. That means they are very serious about it. What we can do really is that I immediately call him, I find out what is his defense of doing something wrong, because I need to listen to him. Then I tell him that it was utterly wrong, and not only wrong, it was negligence, and I put it on his file to say that if this happens again, I am afraid that I will have to probably take an action which may come even in your career. Most of the time it works, because I felt that negligence has also occurred with our resident because of overburden. I tell you, we have a 250-bedded hospital across, and at any given time we have 300 patients. And in this season, I get 60 to 70 admissions per day. 10% of patients are getting discharged and 25% are coming in. Now if suddenly an influx of 60 patients in 24 hours, I have a staff which is only likely to do reasonably well only for X number of patients. They are made to do much more. So I imagine some part of negligence is simply to overburden, but that does not allow it to happen. We need to see what next we can do. And I think all that next we can do is that now prioritize who needs your urgent attention, who needs a little less of attention. And even then, I tell them that you must touch every patient, even if he is not urgent, because he should feel that he is attended. You just put him and say, oh, what's wrong with you, fever for a few days, I'll get crocin for you and I will attend to that serious patient and come back to you. He's ready to wait. But if you don't even go near him, he comes back to say, 2 hours and no doctor has seen him. Doctors have been trying their best. So I feel when the mistakes occur, we must pull them up. But we must also be a little sympathetic. Why the mistakes occur? If the mistake occurred in spite of enough time, enough energy and pure negligence, we must take it very seriously. But many times I can assure you it is an overburden. Same thing probably happens in private practice. People see large number of patients when they cannot see. And there is no reason why they should see. There are enough number of doctors, some are waiting to see a patient, they are as good, and some are so busy they don't even do justice. So we must know how to handle the crowd, and you cannot. For example, for me last 35 years I have a joint practice. Today we have 5 pediatricians in the same, because I am not going to see anybody who walks in. But he feels it's important. I will see that he is being seen. I think in a general hospital that's not possible. Today I have to admit everybody who comes to my door. I cannot allow him to go because he may die. The law demands that I do something for him. Where else will he go? Every hospital is overfull. So I need to do that. At many of these BMC hospitals, on one cradle there are 2 or 3 newborns being treated. will it not mean a very substandard treatment? But it is a little shade better than allowing him to die on the road without a medical help. So I think we will have to decide how much we can do better in a given circumstances of constraints, but then many times it becomes an excuse that these are the constraints, and I think we'll have to draw a line between a genuine constraint that you could not overcome and still a possibility of overcoming a constraint. You can't say my management does not give me this. I want you to suggest how you will do without those things available to you. And I think that's a challenge. Everybody can take it. If we start thinking what more can I do in a given situation, I will do my best. But if I keep on complaining, I need more nurses, I need more residents, you can't have more nurses. You will have to learn how to do that. And I think it's possible.
Can I just say something? Just 1 minute, because we talked about administration, I just want to bring in one top point. And that is that we need to start developing standard operating procedures or standard treatment guidelines, none of which really exist to assist those, new residents to know how to handle things, how to do. Of course, we're not talking about being able to implement, and in medicine especially, I know it's difficult, but I think at least 80% of the problems that people face may be taken care of if we have some kind of systems implemented, some kind of processes described, that if a trauma patient comes, all these things are supposed to be done. These are like standard treatment guidelines. Don't leave it to a grand June. I mean, he just joined and he's supposed to know everything. It's likely that he'll make a mistake. And so it's good if you have these kind of treatment guidelines or SOPs just put up there, especially in emergency situations. I mean, for the long-term diseases, perhaps it also requires, we have guidelines, but local hospital-based, exactly as Sir mentioned, that within these constraints and these facilities, what do you do? What do you do if 20 children come in at one time? Do we have a process written down somewhere? We should, because then we'll be able to handle it far better.
No, I think that's such a great point, that the professor is available on call, that as long as it's just 5 patients, we can manage with the existing staff. But if it crosses a particular amount, then you're allowed to call up Dr. Amdekar and say, will you please come down and help me look after these patients? But I think those are valid points, and it's got to be a two-way communication, which means residents also need to let seniors know these are the problems we are facing and this is where we can